Gout, the disease of kings, and the king of diseases. In Arabic, it is called Dat al-Maluk, or al-Nakras. Gout is one of the hyperuricemic syndromes. Lines of treatment of hyperuricemic syndromes. This is the purine ring, the precursor of uric acid. Purines are present in highly cellular foods, example meat, liver, etc. Inside the body, purines are converted into xanthine. And the xanthine is oxidized by the enzyme xanthine oxidase, or simply, XO, into uric acid. If uric acid level increases in the blood, this is called hyperuricemia. Normal level of serum urates is 3 to 7 mg/%. This level may vary according to sex, age, and the catabolic state. The kidney prevents hyperuricemia by excreting excess uric acid in urine. However, the excess urate in the glomerular filtrate may induce interstitial nephrites and may be precipitated in the renal passages in the form of multiple, friable urate stones. If the kidney cannot compensate for the hyperuricemia, urates may precipitate in the soft tissues, in the form of tophi, which may lead to disfigurement. And sometimes, urates are uptaken by neutrophils, inducing joint inflammations, called gouty arthritis. Allopurinol and Febuxostat inhibit the xanthine oxidase enzyme. Uricosurics increase the excretion of urate in urine. Colchicine inhibits neutrophils' functions. NSAIDs are nonsteroidal anti-inflammatory drugs. In birds, the uric acid can be converted into allantoin by the uricase enzyme. Pegloticase is a recombinant uricase enzyme. Colchicine is the most specific drug for gout. The inflammatory reaction in gouty arthritis starts by recruitment of neutrophils, which is achieved by leukotrienes, example LTB4. The migration of neutrophils to the site of inflammation is achieved by the microtubules. Microtubules are formed from the tubulin protein. Not only the migration of neutrophils that depends on the microtubules, but also the phagocytosis of urate, and urate internalization into the lysosomal vesicles. Rupture of the lysosomes can release the lysosomal enzymes and induce the formation of leukotrienes and prostaglandins. These inflammatory mediators can induce gouty arthritis. They are also involved in sarcoid arthritis, one of the granulomatous diseases, and the acute Mediterranean fever, or the periodic peritonitis. Colchicine binds to the tubulin protein, thus inhibiting microtubules formation, and subsequently, neutrophils migration, phagocytosis, and release of inflammatory mediators. Colchicine, also independently, decreases LTB4 generation. The most common adverse effect of colchicine is diarrhea, because colchicine arrests the mitosis, and subsequently cell division. Intestinal mucosal cells are the first to be affected, since they have very rapid rate of turnover. They are replaced every 3 days. The most serious adverse effect is bloody diarrhea. Bleeding leads to shock and collapse. Colchicine, on long-term use, may lead to additional adverse effects. For example, myopathy and neuropathy, and falling of hair, since the rate of hair turnover is 70 days. Also decrease in white blood cell count, since they arrest mitosis in the bone marrow. The red blood cells are not affected, since their rate of turnover is 120 days. Allopurinol is the second specific drug for gout. However, it is not intended for the acute attack, but rather, for in between the attacks. It is the first choice, and the most commonly used drug, for gout prophylaxis. Allopurinol's tablet is either 100 or 300 milligrams. It is used 3 times per day for life. It is a xanthine oxidase inhibitor, thus prevents synthesis of uric acid. After initiation, it precipitates acute gout in about 6% of cases. So, it is advised to give a drug to abort the acute attack, e.g. corticosteroids, at the initiation of treatment. The most serious adverse effect is a form of hypersensitivity, associated with fever, and internal organ damage. Other adverse effects include skin rash, nausea, and vomiting, decrease white blood cell count secondary to bone marrow depression, peripheral neuritis, and interstitial nephritis. Febuxostat is an alternative xanthine oxidase inhibitor. It is more potent, and accordingly, it is given as 80 mg tablets once per day. It is also claimed to be more effective than allopurinol. It is well tolerated orally. It rarely increases hepatic enzymes. However, post-marketing reports showed that it increases cardiovascular events. This limits its use, since hyperuricemia is usually a part of the metabolic syndrome, in which hypertension is the major player. Uricosuric drugs are the drugs that increase urate excretion in urine. This is a diagram for the nephron. There is a carrier for uric acid absorption, in the early part of the proximal tubules, called URAT1. It reabsorbs all the amount of uric acid filtered in the glomeruli. This is a protective mechanism, to guard against uric acid precipitation in the tubules. Since uric acid is poorly soluble in water, some uric acid is secreted again distal in the nephron. And again, some of the secreted urate is reabsorbed, to prevent urate precipitation in the tubules. The net rate of urate excretion is 10% of the initial amount filtered. This is enough to keep serum urate in the normal range. Uricosuric drugs, for example, sulfenpyrazone, probenecid, and benzbromaron, inhibit the URAT1 carrier, thus increasing the amount of urinary urates. Benzbromaron is the most commonly used one. However, because of the risk of hepatotoxicity at full doses, it used as additive drugs with allopurinol at reduced doses. The increase in urate excretion necessitates intaking of large volume of water, and turning the urine alkaline, to guard against urate precipitation in the renal tubules. It is worthy mention that aspirin, as an analgesic, is not preferred in gout treatment, because it inhibits urate secretions at doses less than 2 grams. Pegloticase is the most potent hyporacemic drug. It is porcine, recombinant uricase enzyme that converts uric acid into allantoin. And it is the only parenteral drug for gout prophylaxis. It is given by intravenous infusion, every 2 weeks. However, since it is a serious foreign protein, there are many precautions during administration. First, measure the uric acid level before each administration, to judge efficacy. If uric acid is normalized, do not give the next dose. Second, other drugs that combat hyperuricemia should be withheld, so as not to give a false impression that the drug is effective. Third, since this is a foreign protein, hypersensitivity is expected, and pre-equals medication with anti-allergic drugs, as antihistaminics and corticosteroids are needed. Last, this drug may precipitate acute gouty attack in up to 70% of cases, so, drugs for acute gout are combined with it in the first 6 months.